I would like to welcome you all to the Society Skeletal Radiology Resident Education Club webinar. My name is Zachary Stewart, a musculoskeletal radiologist at Mass General Hospital, and I will be serving as the moderator for this session. It is my distinct pleasure to introduce your speaker for this webinar, Dr. Resten Imaoka. Dr. Imaoka did his radiology residency at RWJ Barnabas Health, Rutgers Radiology Residency in Livingston, New Jersey, and fellowship in musculoskeletal radiology at Washington University in St. Louis, Missouri. He is currently serving as an assistant professor of radiology and associate director of interventional radiology, musculoskeletal interventions at Washington University in St. Louis. It's all yours, Dr. Imaoka.
Thank you everyone for joining me today. I'm very excited, to be able to talk here and talk a little bit about my passion in MSK radiology, which is the interventional aspect, and more specifically, give you guys a little bit of an intro to how MSK can play a role in interventional oncology. So before I get to the talk today, which is about spine tumor interventions, I did kind of want to just talk a little bit briefly about kind of my path to MSK. So I imagine, like many of our listeners today, one of the reasons that MSK was desirable to me was the ability to have a nice mixture of both diagnostic and interventional roles. And most of the time when we think about interventional or procedural aspect of MSK, we're thinking of things like image-guided biopsies or injections, things like that. Which was really what my experience was as a resident in New Jersey. But hopefully today I can expose you guys to a whole nother field of MSK interventional radiology, where we can have a massive clinical impact, and that's in the field of interventional oncology. So a little bit about me. I started off actually in general surgery and did 3 years of that before I decided to switch to radiology. So the procedural aspect, was always a big part for me. It was always very appealing, and that's why MSK was always so appealing too. But I didn't really know the extent of how impactful we could be in MSK until I came to WashU and did my fellowship here, where my mentor, Jack Jennings, who is very well known and respected for his work in interventional oncology across the world, really showed me, what the possibilities were for MSK. So, although the focus today, today's talk is on spine mets and interventions, because of, as many of you already know, that spine is the most common site of metastases. There are plenty of other locations throughout the body, whether it's the pelvis, chest, abdomen, extremities, where MSK can play a huge role. So I was really lucky to be exposed to this world of MSK interventions and interventional oncology by Jack, and hopefully by the end of this talk today, some of you guys will also be interested in pursue a career in interventional oncology. This is my email up here. Hopefully you guys can see this, and always feel free to reach out to me. I'm always available to answer questions or anything like that, so don't hesitate to reach out. Okay, I've got nothing to disclose. So today we're going to talk about spine interventions and our objectives. We're going to talk about metastatic spine disease. We're going to talk about thermal ablation in the spine, specifically with a focus on radiofrequency ablation and a little bit of cryoablation. And then we're going to talk about how we work up these patients, like who are we selecting, who's appropriate for these types of interventions. And then I'll kind of go over the procedural steps as well. So cancer diagnoses, as we all know, always on the rise, right? If you look at the world in 2022, there are almost 20 million new cases and 10 million deaths. And by the time 2050 comes around, we're going to have 33 million diagnoses and 18 million deaths. So that's an increase of more than 50%, in the next 25 years. In 2025, we had an estimated more than 2 million new cases of cancer were diagnosed. And then 600,000 people were unfortunately going to die from it. So in general, cancer rates are going to be highest in countries whose populations have the highest life expectancy, education level, and standard of living, right? And that kind of makes sense, right? There are always going to be your advances in chemotherapy, immunotherapy, and people who are fortunate enough to have access to those treatments or have longer life expectancy are unfortunately going to have more diagnoses of cancer. So if we look at these numbers here, prostate in men, lung and colorectal are the most common. And then women, you're going to see breast, lung, and colorectal. The latest numbers based on data from 2021 say that, almost 40% of people are going to be diagnosed by cancer at some point in their life, unfortunately. And when we talk about metastases, specifically skeletal metastases in general, for adults that are older than 25, the most common primary site is going to be lung, followed by prostate and breast. And for the younger patients, less than 20, those are going to be more of your endocrine cancers, soft tissue sarcomas. So why is our focus on spine today? Well, these numbers are basically the reason. This is from data that is actually decades old at this point, but the spread still remains true. Right. So if you look up here, we've got spine mets as the most common site of your cancer metastases, which is, over 33%. That's followed by your pelvis and sacrum, and then you start to see some of your other longer bones here, right? Femur, ribs, humerus, skull, things like that. So spine, very common, right? We know it's very vascular when you have things like Batson's plexus, those valgus, venous portions that just go straight into the vertebral bodies. It makes sense why you're getting so much disease to the spine. So what is our role? Right? Where do we fit in as musculoskeletal interventionalists? What are the objectives when we are seeing these patients and evaluating them for treatment? What can we do for them? So the main thing that we are trying to accomplish here are decreasing skeletal-related events, reducing that pain, improving the quality of life, and then obviously also the potential for local tumor control. And when we talk about skeletal-related events, we're talking about things like pathologic fractures, right? And that's obvious. You've got disease in your vertebral body. There's a fracture associated with it. That's going to be painful. They could just have run-of-the-mill bone pain, right? There's no fracture there yet, but they have cancer that is eating away at that bone, and that's developing bone pain. You could have epidural cord compression or femoral stenosis. This one is particularly morbid. A lot of the times patients, they have their diffuse bone pain from their skeletal meds, and maybe their pain is controlled with their narcotics, but oftentimes they develop this progressive epidural or femoral component, and it becomes extremely morbid and limits their daily functions. And, unfortunately, we often see these patients for the first time at this stage of their disease as they're referred to us by their oncologists or their radoncs or other palliative teams, when those teams are really unable to control that pain with medications. Right? In a perfect world, we would catch or we would be a part of this patient's care at an earlier stage and potentially prevent these types of things from happening. But, that's a big part of this is there's a knowledge gap, where oncologists and radiation oncologists don't necessarily know the procedures that we can offer and the outcomes that can come from those. So pain. When we talk about pain, pain comes in many flavors when it's regarding cancer. So that could be mechanical pain, right? This is a little bit more of an obvious one. Pain due to a pathologic fracture and or the instability and mechanical pain of that axial loading on the spine and the movement of those unstable fragments. It could also be oncologic, right? It could be due to any of the many ways that nociceptors are stimulated by the tumor-associated immune cells, or any component of the tumor microenvironment. And, not surprisingly, a significant amount of pain is localized at that bone-tumor interface where a lot of these changes are happening. And aside from that, tumor growth can also directly invade nerve fibers as well as induce nerve sprouting, which affects both sensory and sympathetic nerves. This little insert here is the gray paper, which shows how sarcoma in a long bone, which is actually shown here in green, actually causes some disordered pathologic nerve growth and neuromas that form both within the medullary canal, which are these orange signals here, as well as along the periosteum too. So unfortunately, a lot of bone or abnormal nerve stimulation causes some pain too. And then, as I mentioned earlier, radicular pain, right? These are often how these patients will present to us. They may have initially had that initial dull, constant oncologic pain that was either controlled or maybe even tolerated with oral medications, but eventually progressed to something like this, where, here we've got a lesion. This is a fat-suppressed T1 post-contrast lesion, where you can see there's a significant epidural component here and then a femoral component here, which is causing some stenosis. And this is where they end up getting those radicular pain or myelopathic symptoms from all this epidural and soft tissue components. So why do they present to us so late, often so late in their disease? And as I mentioned before, a lot of that is due to a knowledge gap. So I'm sure, many of you or all of you have heard of the NCCN, right? The National Comprehensive Cancer Network. They put out guidelines, they update them or try to update them every year. And these are essentially the Bible for our oncologists. They've got these great flow charts and diagrams, which make it very easy to follow a treatment algorithm and very easy to follow. So, here's an excerpt. This is from the adult cancer pain from the most recent version here. And here, at least we can see, at this area, local bone pain. You can consider local radiation therapy, nerve block, vertebral augmentation, or percutaneous ablation techniques. So this is good. We worked very hard to get this into the NCCN guidelines so that we can have a presence like this. And it's great when our treatment options do show up in the NCCN because we know that plays such a large role for the oncologist. But on the other hand, you get a flow chart like this. So this is for non-small cell lung cancer, which, as you may remember, I pointed out earlier that lung cancer is the #1 primary to metastasize to bone. So if we look down here in the bone metastasis section, they talk about things like orthopedic stabilization. Maybe you consider your palliative external beam radiation therapy or bisphosphonates, right? But there's no mention here of any percutaneous ablations or augmentation or anything like that. And this is kind of where that knowledge gap I was talking about comes into play. So we've already done great work getting into portions of the NCCN like adult cancer pain, but you can kind of see here that there's a lot more work that's needed. And when the oncologists or rad oncs are following these guidelines to a T, it's kind of easy to see why patients with painful bone mets are immediately referred to rad onc for the palliative radiation therapy, but there's no thought of any percutaneous ablation or augmentation, whether that's in the spine, pelvis, any other bone, or even within the soft tissues. So a lot more work to be done just to make sure that people know that we can do what we can do. So because of that, it's not surprising that the current standard of care for people with focal bone pain related to bone mets is opioid or non-opioid analgesics and radiation therapy. For radiation therapy, it's typically palliative, and that means like a lower dose, right? 8 gray in a single fraction is a pretty common one. Now we're starting to see a little bit lower, maybe 5 grays, but they're decently low doses, and the response rates, unfortunately, aren't great. Right? If we look at this, the complete response rate is only seen in 22% of people for doses of 8 gray. This is a palliative dose. And even worse, I think, is if you look at the partial response, that's seen in only 38% of people, right? So over 60% of people who are receiving palliative radiation for their focal bone pain from bone mets are getting no relief whatsoever. Add on top of that, the kind of low efficacy of it, the result is also delayed too. So after radiation therapy, if you get any pain relief, it may even take as long as 4 or 6 weeks after treatment completion to really start feeling that. So makes sense, right? A large percentage of patients are still going to feel moderate to severe pain after their radiation therapy or while they're still on their opioids or non-opioid analgesics. And for a lot of these patients, the only remaining option is to increase those systemic analgesics, unfortunately. So when we talk about, the start of RFA for bone mets, we kind of got to go back to this study, which was a really important study back in 2004, primarily out of Mayo. Here they had 43 patients and ablated lesions in the spine, and they saw that these patients initially had a pain score of 7.9 out of 10, and that improved to 4.5 and even down to 1.4 at 12 and 24 weeks. So, thanks to Matt Getz and his colleagues, we've really started to realize that, hey, we can do a lot more for these patients instead of just increasing their doses of opiates or non-opiate medications to no end, or just crossing our fingers and hoping that, palliative radiation therapy would take all their pain away. And then thus we started seeing and treating a lot more patients for bone pain, specifically from these metastatic lesions. So who is going to benefit from ablation? These are the typical things that we see, patients who have pathologic fractures, people who have epidural disease, right? As I mentioned before, right? Like in this example here, you can see this patient has some epidural disease anteriorly here. Radioresistant tumors, that's something we have, we talk about a lot. Historically, we think about things like clear cell renal carcinoma, melanoma, different types of sarcomas, right? Those are all historically radioresistant types of tumors. And, some, rad-oncs will tell you nowadays, with the SBRT, which is stereotactic body radiation, if you're able to get higher doses, some of that radio resistance, it kind of becomes not as relevant anymore when you're comparing to conventional external beam radiation therapy. because they're able to, kind of shape their fields to limit toxicity to adjacent structures like cord, nerves, and bowel, et cetera. But, when you're close to the spine or nerves like this and you aren't able to get that full radiation dose, then the fact that they're radioresistant tumors, that kind of comes back into play again, unfortunately. So people who have failed radiotherapy, good candidates, oligometastatic, oligoprogressive disease. I actually just did a patient today who had metastatic breast cancer, who had this one lesion that was progressive on her ribs and it was invading into the intercostal nerve. So I ablated that because all of her other lesions were completely stable. So, oligometastatic, you potentially could be going for cure there too. So these are all great candidates for potential ablation. And then, of course, people who, for whatever reason, cannot undergo any other palliative treatments, whether that's like they're having concurrent systemic therapy, maybe they're enrolled in a different study trial or something like that. And then added here, question mark asymptomatic lesions. There's data, from the Radon world where who are asymptomatic with, patients who have asymptomatic spine meds were treated with RT and they showed a trend of decreased skeletal related events, right? So that's fractures, pain. So there's current trials going on whether they're starting to treat these asymptomatic metastatic lesions. And I think that, might be something that spills over to the IR world, and we may start seeing instances where we're treating these asymptomatic lesions as well. So patient workup, you really cannot overstate the importance of a multidisciplinary tumor board with your oncologist, radiation oncologists, orthopedic spine surgeons, orthopedic oncologists, whatever. If you really want to be, or if you want to be a successful interventional oncology practice, or you want to build a successful interventional oncology practice, you really have to be able to insert yourself into these tumor boards and be available. And as I mentioned before, multiple times, there's often a knowledge gap where the radiation oncologists and the oncologists just don't really know what kind of stuff we can provide for them and how good the results have been. So making sure that you're an active part of the tumor boards is imperative. So like here at WashU, aside from our normal sarcoma tumor boards, we also have weekly spine tumor boards and weekly orthopedic oncology tumor boards run by us specifically in MSK, where we're specifically going over these cases and talking about the potential percutaneous interventions that we can offer them. Um, So patient workup continues, preoperative imaging, right? You're going to have your MRIs, your CTs, your radiographs. We see them in consultation. We're going to be doing a very detailed history and physical examination to determine what this pain is and whether or not it would be affected by us, whether we can treat it. We talk about the need for things like general anesthesia versus sedation. We start thinking about how we're going to be doing these procedures, right? What modality are we going to use? What nearby structures do we need to potentially protect? And that kind of helps us decide, right, whether we need to do general anesthesia or we can get away with doing something like sedation. So one of the things that we go over a lot in spine tumor boards is the spine instability neoplastic score. Some of you guys may be familiar with this already, but um, it's basically a score where you have a scoring system in different locations, tumor types, or locations within the vertebral body, and physical exam findings all give you a certain amount of points. And those certain amount of points are going to determine whether or not that patient needs to go to surgery or potentially they could do something percutaneously. Right, so location, pain, lesion characteristics, alignment, and posterior element involvement are the main categories of the SINs, and you can see down here the scores, right? We tend to treat people here in this region where they're potentially unstable. They have 7 to 12 points on the SINs, right? If you're seeing people who are 13 plus points, those are usually surgical candidates. The surgeons are taking them immediately to the OR. So if we're gonna deep dive a little bit more into SINs, first part was location, right? So depending on where you are in the spine, you're gonna have more points, right? So if you have something in the junctional spine, whether that's the occiput C2, C7T2, T11L1, etc., that's gonna be the most points, which is 3. If it's mobile, C3 to C6 or L2 to L4, you get less points at 2. If it's semi-rigid, right, in the mid-thoracic spine, you get even less at 1 point. And if you're way down in the sacrum and where it's fully rigid, you get 0 points. And then we talk about pain, right? And this is a thing that we can't really tell from just looking at their MRIs or their CTs. This is where that physical examination, detailed history really comes into play. So mechanical pain gives you 3 points, right? These are people like maybe this guy here, unfortunate guy who's maybe describing that he's got pain after prolonged standing or sitting, right? Maybe he's been walking around a museum like this for all day and now he's got some back pain. It's relieved when he's laying down. Other ones are maybe like this woman. Maybe she's talking about she feels a lot of pain where she's bending over to pick something up, right? Both of these are very common examples of pain due to axial loading, and especially when it improves with recumbency, right? That's mechanical pain. That's 3 points. A lot of pains will have pain like this, right? Occasional pain, but not mechanical, and that's going to be primarily your oncologic pain, right? Remember, as that bone kind of is eaten away by that tumor, right? You're going to have pain from that too. The lesion itself, the quality of it, it gives you points. So is it lytic, right? So this patient here, metastatic thyroid carcinoma, you can see he's got essentially just a giant hole in his thoracic spine, right? And it's both, within this entire vertebral body, but it goes up through the discs into the vertebral body above and below it, right? So this is a lytic lesion. This would be the worst. So it gives you 2 points. Surprisingly, this guy hasn't collapsed yet. Is it mixed, right? So we got both blastic components, sclerotic components mixed in with some lytic components here we can see nicely on the CT, or is it just purely blastic, right? This person has multiple chronic fractures here. You can see it's metastatic prostate, right? So all these little blastic lesions here in the setting of this otherwise osteopenic bone. Alignment, again, this is something both on physical exam and on imaging, right? So if you got somebody who's subluxation or transluxation, that's very bad, right? 4 points is a lot. So this person here has a little bit of anterior subluxation within their T-spine. If they're kyphotic, right, like this one here with this pathologic fracture, that's also 2 points. So any of these things are all, signs of potential instability and are going to give you more points. And then posterior spinal involvement, right? So if you have involvement of your posterior elements or facets, you're going to be more likely to be unstable. And if you have it bilaterally, obviously that's going to be a little bit worse, right? So we've got an example here where we've got this lytic lesion and this left pedicle is completely destroyed. This one's actually crossing the lamina, so it maybe it's a little bit of both posterior elements, but this was my example of a unilateral here. And then here's a bilateral, right? You've got lytic lesions, maybe a mixed lesion here in this lumbar spine. You can see both of the pedicles are involved and it's coming down the transverse processes as well. So anybody with 7 or more needs to have a surgical eval, right? And this is where that discussion in your multidisciplinary tumor board is so important, right? Your surgeons are going to be evaluating these patients. They're going to tell you about their exam. They're going to tell you how concerned they are about instability, right? If that matches up with what you're seeing radiographically, then you can choose the appropriate therapy for that patient. So aside from the sins, the thing that we talk about a lot is how much epidural disease there is, right? So there's a scoring scale called the epidural spinal cord compression, also known as Bilski, right? You guys may have just heard it as the Bilski scale. And this is talking about the epidural disease and how much there is and what it's doing to the cord and all the CSF around it. So if we look at examples here, grade 0 is just a lesion in the bone itself, right? So you got this lesion up here in the vertebral body. You can see the cortex is intact. There's no epidural disease at all here. Here on grade 1A, you can see that there is epidural disease. It may be a little bit hard to see, but here along the right pedicle, there's a little bit of signal there that you can see, intermediate signal that has some epidural disease, but you can see that the sac itself is completely normal. Still looks like a normal donut there. Here, 1B, you have that epidural disease. Now we're at the left side, vertebral body pedicle, and you can see it's indenting the sac a little bit here. 1C is where you have epidural disease and it's abutting the cord, but not compressing it. And then grade 2, we start to get compression, right? So now you have grade 2, which is compression of the cord, but there's still some CSF, right? So on this T2 here, you can see that there's some CSF posteriorly and on the right side. And then the worst, grade 3, is going to be compression without CSF. Right, so this is very important, especially from the rad-onc perspective, because they're usually going to want that 1 to 2 millimeters from the cord so they can give a real SBRT dose. Otherwise, you're looking at lower palliative doses. All right, so now that we've decided a patient is appropriate and would benefit from percutaneous intervention, which ablation modality we're going to choose. And in the spine, this is going to be dominated by radiofrequency. So we have a bunch of heat-based thermal ablations, radiofrequency in the spine by far the most common. And this is using alternating electromagnetic waves in the radio spectrum, so anywhere from 300 to 1,000 kilohertz, which generates frictional heat. If we go up in power, then you get things like microwave, right? This is now in the microwave spectrum. You can see 300 to megahertz to 300 gigahertz. So much larger forces there. You also have HIFU, not too common, or laser, also not very common. And then if we're talking about cold base, cryoablation is what we're looking at there. So cold base uses extreme temperatures with multiple freeze-thaw cycles. Excuse me. That's going to induce liquefactive and coagulative necrosis. So we always do these in multiple freeze-thaw cycles. And initially, the extracellular ice is going to freeze first, and that's going to cause an osmolarity, increased osmolarity, and shift from intracellular water outside. That's going to dehydrate your cell. It's going to shrink it a little bit. And then you're also going to start to see intracellular ice forming within the cell itself, and then also pore formation here from disruption of the membrane. The intracellular ice is going to cause damage to the organelles. And then as you thaw, that kind of reverses. So the thawing cycle, water goes back into the cell, it swells, it bursts. There's endothelial damage that happened before, and we get even more edema, so even more swelling in this region. And then you repeat the whole thing over again, you freeze it again, and then we get the delayed reaction where we see the neutrophils, the macrophages show up, they release some cytokines, you get a big inflammatory response, and then that induces a lot of cell death. Okay, so I always think it's kind of interesting to just kind of a little bit of history of how we got to kind of where we are today. So, I feel like it always starts with, the ancient Egyptians, right? They're always who we think of. It seems like they're always there when we're talking about innovation and leaps and bounds or the roots of many things, not just in medicine. But the Egyptians and Greeks here were the first to really describe heat to use to cauterize ulcers or growths. In the late 1890s here, we start to see some more descriptions out in France, where Jacques and Tesla are talking about using kilohertz current that's injected into the tissue, which can cause heat, but then does not cause those muscles to contract or cause any pain. This picture is from Tesla's workshop. He created the transformer, which produced high voltage currents and really led to a lot of the developments in RFA. In 1931, we got this German surgeon, Kirschner. So he described the first placement of percutaneous electrodes for treatment of trigeminal neuralgia. And his treatments were based on pain treatments that were used in the First World War. So this is actually a picture from that time where you can see this person is using electricity or currents to help with this guy's pain. And so you guys probably recognize this name as Kirschner from K-Wires, but outside of his surgical accomplishments, he played a major role in the development of RFA, especially in the chronic pain world. 1950s, we finally got that first commercial available RFA device, and it was really mostly for chronic pain and neurologic conditions. And then finally in the 90s, out in Italy, we got Tito Lavraghi, who was the first person to use RFA in a tumor, and specifically hepatocellular carcinoma. And he demonstrated the efficacy and safety of it as a minimally invasive treatment for tumors and played a huge role for development of RFA to be adopted into the world of oncology. This is what he looks like there. Okay, so ablation systems, there's many out there in the world of interventional oncology. These are some of the big players, Medtronic, Merit, Stryker. They all are pretty similar, right? We're always doing bipedicular. We're coming in from both pedicles when we do these ablations to try to kill, as much of that vertebral body as possible. When we talk about how it works, we still occasionally do see people that are using monopolar devices with RF. But really, when it comes to tumors, the bipedicular approach, the main hitters are all bipolar, where you've got an active and return electrode in the same instrument. And that limits the area of thermal spread, but notably does not have the disadvantages of monopolar, which are, large volumes of tissues that get injured, distant burns, especially at your grounding pads if that's not appropriately put on. And then also, monopolar can interfere with pacemakers too, right? So bipolar for tumors, essentially everybody is using these now. When we talk about RF, it is impedance based and it's resistive heating, as I mentioned before. So medium frequency currents, it causes agitation of tissue, ionic molecules producing frictional heat. And that kind of happens kind of centrally within the ablation zone here. The extent of necrosis kind of depends on the amount of temperature generated minus the heat loss from cooling effects of adjacent blood vessels. You can see that the majority of it is the resistive portion is here kind of at the center, and then the rest of the ablation zone is actually just from conductive transfer, right? So the heat from here just transfers out into the remaining soft tissues. But when we talk about things like heat loss, depends a lot on tumor histology or adjacent blood vessels. Tumors that we know that are very vascular, and we think of things like clear cell renal cell carcinoma, medullary thyroid, stuff like that. Because they're so vascular, you'll experience a lot of this heat sink, and it may take longer to get the desired temperatures. So here you can kind of see just what that kind of looks like, right? The temperatures at the center of the ablation zone and how that kind of expands out here. Um, this particular example here has thermocouples on it, which we feel is great, right? This gives you a temperature reading, so you know exactly what the temperature is a certain size away from the center of your ablation zone. And that allows you to really have real-time assessment of that temperature spread and have a good idea of what your ablation zone is. So that allows RFA to be controlled, very safe, very predictable ablation zone. And another reason why RFA is so safe in the spine is because it's impedance based. Things like an intact cortex are very resistant to the energy spread and does not really, therefore the energy does not traverse it, right? So this is, of course, more difficult in patients where their cortex is destroyed, right? You got somebody like this where they've got all these holes in their cortex, or worse, if they have no cortex back here close to the spine. In those cases, you're going to have to be a little bit more careful, potentially employ some thermoprotective techniques, which we'll really talk about later on. So is it safe? All right, this was the largest retrospective series. This was put out of our institution here at WashU. We looked at 266 lesions in 166 consecutive patients, looking at pain palliation, specifically looking at, is it safe? And it is. So overall complication rate of 3%. Only one major complication rate, which was a spinal venous cord infarct, and that may have been due to the other medications that this patient was particularly taking as well. But minor complications, right? 7 out of 266. Most commonly, it's going to be periprocedural transient radicular pain, or some asymptomatic spinal cord edema on routine follow-up, just no symptoms whatsoever. Or, back in the early days when we were doing RFA on the spine and we did not routinely cement it, you could see something like this where you get delayed fractures secondary to the osteonecrosis that you're inducing from the spine. So RFA is definitely safe in the right hands. When we talk about things we worry about, thermoablation is the main thing, right? So the way that you're going to see that, right? If you're ablating a nerve, they're going to present differently. They could have anesthesias, they could have paresthesias or dysesthesias. Obviously, if you ablate a motor nerve, they're going to have paralysis or paresis. Peripheral nerve injury could be temporary or permanent, right? Depends on how bad you're killing that nerve, what sort of injury level you're getting. The interesting thing about heat is that it's variable both on the temperature and then also the amount of time you spend at that. Right. So if you're talking about nerves specifically, which are very sensitive to heat, you could spend maybe 46, you could get to like 46, 47 degrees for like maybe a minute and have no problems. But then you could spend, 10 minutes at like 44 degrees and have problems. So for heat base specifically, it's both a function of time spent at that temperature and the actual temperature. For ice, it's a little bit different. Nerves, again, very sensitive. So you could even have positive temperatures up to 10 degrees where you are actually causing nerve damage. And then this is kind of just how that nerve damage kind of works. So when we talk about thermal protection, specifically in the spine, and we're talking about RFA, we like to talk about conscious sedation and the patient's biofeedback being the best thing to let you know, right? They're going to let you know if you're pissing off a nerve, whether they get some radicular symptoms around wrapping around their chest, or their abdomen, wherever you are. They're going to let you know for sure. So there's a couple ways to achieve thermal protection, right? You can talk about passive control where you put thermocouples, which are just temperature sensors, right? You put it close to something that you want to see and measure the temperature. Or you could do evoked potentials, motor or somatosensory evoked potentials, where you're stimulating the brain, seeing how long it takes for that muscle to contract, right? And you're measuring both the strength of the contraction or the amplitude, and then also the delay, the latency. And then active control is you're actually doing something to prevent it, right? These passive ones, you're just watching, but not really doing anything to prevent it. So for active, commonly it's things like CO2 insufflation, or maybe even D5W insufflation, something where you're physically moving the things you want to protect, whether that be skin or nerves, away from the ablation zone. You could use balloons. You can also warm, right? We do warm towels over the skin when we're doing like a cryoablation. It is important to remember that if you're doing any hydrosection, you do want to use D5W because saline is ionic. RFA is going to go through that ionic. It's going to use that as a conduit, and you're going to basically extend your ablation zone to places you don't want to go. And then if you're really in the spine, close areas, you're talking about myelograms, epidurograms, things like that to displace the cord. So here's an example of a thermocouple, right? This is the patient who got RFA of his L4 and L5. You can see this is that epidural example there. These are the ablation probes coming in through the pedicles here. And then these little things down here are the temperature sensors, right? So that's sitting in the foramen. You're measuring the temperature there next to the nerves to know how close you are getting to that 44 degrees, and whether or not you got to give them a break. We usually would only do this if they're under GA. Usually we like to prefer the biofeedback for 4 hours. The neuromonitoring, motor somatosensory evoked potentials, again, I mentioned, right? You stimulate the brain, you measure contractions down at the wherever muscles you're checking, or you stimulate the muscles and you see how far the somatosensory is going back and forth, right? And so you're looking at these waveforms throughout. Any changes in the delay or the strength of it is going to be something bad, and you're going to want to back off from what you're doing. Here's an example of more active thermal protection, right? Here we're doing a cryo of the posterior elements of the spinous process. You got a needle coming down. We're getting an epidural with contrast here to physically displace the thecal sac and the cord away. And then you can also see a little bit of CO2 here in the subcutaneous tissues to push the skin away from the tumor here. So talk a little about the safety, and here we'll talk a little bit about the efficacy. So this is a relatively recent trial, Opus 1, talking about the efficacy of treatment of these spine tumors with RFA. So you can see down here, really what we're looking at is more than 50% had a clinically relevant improvement, which is defined as 2 points of improvement on the Brood Pain Inventory at 3 days, which already is better than, palliative RT. And then 75% had clinically relevant improvement at 1 month, and then 85% had an improvement at 6 months. So this is, very good. It showed that it's very effective at limiting that bone pain, potentially skeletal-related events that come with all these spinal mets. And so what might your typical patient look like? This is a patient we did relatively recently. She's 36, metastatic colorectal cancer. If we look at her imaging here, when we calculate her SINs, we gave her a score of 8, right? So her location is L2, that gives her 2 points. She did have mechanical pain, so that's 3. If we look at her lesion here on the CT, you can see there's both lytic portions and sclerotic portions or blastic portions, so it's mixed. She does have a slight fracture to it, but it's less than 50%, so that's 1 point. Alignment was normal, and then she did have unilateral involvement, which is a little bit hard to see on this particular one, but she got a SINs of 8. Bilski score was 3, right? This is what this is showing here. This is a T2, and you can see the epidural components here, but more importantly, what you cannot see is that there's no CSF around these spinal nerves at all. So Bilski score of 3 for that. This is what it looked like after we ablated here. So again, you can see this is the T1 Sag post. You can see there's a little bit more space here between the tumor and the nerves compared to this one over here. And then here on the T2, you can see now some of that stuff has retracted. We actually do see some CSF now within all these nerve roots. And again, a lot of these patients are treated with RAD-ONC at the same time. So this was just what their mapping kind of looks like. You can see how they conform their radiation to the vertebral body. And this person ended up getting 20 gray. So that's kind of how that works. We'll just go over now kind of the procedural steps of how you would do ablations. And so this is an example on a 64-year-old guy. He's got colorectal cancer. It's painful, and he has this one oligoprogressive lesion at L2. He does have other mets in his liver and other locations, but this is the only one that's growing in his on his chemotherapy. So here you can see the T2, it's really localized only in the vertebral body, right? There's no epidural disease at all here. The post shows that it's probably a little centrally necrotic here. We got some peripheral enhancement, and then stir in the Sag on the Sag stir and the Sag 2 post again showing the same thing, right? So as maybe you guys have seen already when you're doing these types of procedures, whether or not you're doing biopsies or kyphoplasties, we'll start out with your fluoroscopy like this, and we're always going to be starting on the lateral aspect of the pedicle, right? Right. The most important part where you potentially is going to get into trouble when you're doing these types of procedures is violating that medial wall of the pedicle cortex. So we'll always mark that upper outer side of the pedicle. We'll confirm as we put our needle in as we're going in to make sure we're straight in the middle of the pedicle, right? The ideal goal is to get right in the middle of the vertebral body so that you're ablating as much of the entire vertebral body as possible, right? We kind of approach this the same way a rad onc would approach it, which is to treat the entire vertebral body, even though there may be, the MRI may show that there's only a small lesion on the right side. There's always some micro disease that you cannot really see that well or cannot appreciate on the MRI. So we always try to treat it as much as possible and do the entire thing. As you're putting your needle in, you're going to be checking your APs a lot, right? You need to either um, check here on your AP where you're a true AP, so you're looking at your spinous processes, where they're going to be equidistant from your pedicles on the right and left here, and you're really looking at that medial wall of the pedicle, right? So this is a nice view. We show the needles coming in, it's in the pedicle, but we have not violated that medial wall. Once you get to that posterior pedibonical junction, that's that critical point, right? If you are at this location with the needle tip on your sag, you come back here to your AP and it looks like this, then there's essentially no way that you're going to go too far medial and get into the canal, right? Because you've already passed it at this point. So at this point, you can really try to get even more medial if you feel like you need to cross midline. In this particular example, this vendor has a curved osteotome. So here you can see we're coming in, the osteotome actually curves across midline to make channels for the radioablation probes, right? So this one, on the very distant one, we actually want to go, we don't want to cross midline, we kind of just want to meet it in the midline. And so you kind of get down and then you get your osteotomes that you're just about a spinous process distance apart. So this is the right side, the left side, and here on the right side, you can see we're stopping at the same thing here with our osteotome, and then eventually we're putting our probes in, right? So again, we always do this in a bipedicular fashion because we're trying to kill the entire vertebral body, just in case there's disease that we cannot appreciate on your PET or MRI. So here you can see they're spaced out, a decent amount apart, right? Because the RF goes a little bit beyond these electrodes here too. So we're very far anterior, and we're about a spinous process apart. These ablation probes, depending on what you're using, you will know the size that it makes, right? So we happen to know for this one, the largest it's going to get is about a 3 by 2 centimeter ablation zone, which means you're probably not going to get the entire thing, right? So we're going to center one ablation zone up front, where the center is right here, and we're going to get an ablated portion of the anterior vertebral body here. Then what we're going to do is we're going to pull that back and do the same thing, right? And so now we've centered our ablation zone in the posterior vertebral body. We're still about a spinous process apart because these ablation probes can curve and we can steer them to where we want. But this ensures that you're going to ablate the entire vertebral body. Then I didn't include in here, but we would also pull them back if there's disease going into the pedicle, right? You can keep them straight, pull it back to the pedicle, and burn into the pedicle as well. And then after that, you're going to treat it like you would to any other normal kyphoplasty, right? So here you've got your osteotome coming across midline. Here you're creating a channel for your balloon to follow, right? So this is your balloon. You're going to center that in the middle, right? Again, we're using a true AP here. So we've got a spinous process in the middle, right between our pedicles here, and you're making a cavity, right? And the goal for kyphoplasties is a cavity creation or a cement filling from pedicle to pedicle and superior to inferior end plate, right? Depending on the fractures, if there is a fracture or not, you may not get up here, right? If it's healing on its own, sometimes it's so sclerotic, it just forces the balloon one way or the other, but that would be the ideal goal. And then you're just going to fill this in like any other kyphoplasty, right? So we got a curved delivery cannula here. It's putting in cement in. And we, again, trying to make a creation of cement from pedicle to pedicle and then superior to inferior. So that's as it's filling. And then you get something that looks like this, right? So this was that sclerotic lesion that it didn't really fill that well, but everything else we filled in very nicely there. So this vertebral body is not going to collapse. And then this is what it looks like, about 2 months out. All right, so here we got our T2s or T1 posts. You can see the post-ablative changes here at all this cement and dead stuff here. And then it is normal to see this rind of granulation tissue at the periphery of the ablation zone, right? So this is not like any residual disease or anything. This is just viable granulation tissue at the edge of your ablation zone. And if we look at a CT 1 year later, so these left images are the initial, these right images are obviously the post with the cement in place. So you can see 1 year later, he did absolutely fine. He did not progress at all. And it's kind of hard to see through these bone windows, but you can see his liver looks relatively normal here, but On this one year later, his liver looks absolutely terrible with all this widespread metastatic disease. So he progressed everywhere else, except for that area that we treated here. So this is good, right? We prevented him from getting that epidural disease back here where he's going to get myelopathic, develop those symptoms, or any sort of radicular pain. So although he progressed elsewhere, we really did provide a good palliative effect for this location here too. We'll just do a very quick example of what cryotherapy might look or cryoablation might look like in the spine. I didn't mention it before, but we don't often use cryoablation in the spine because of the way that it works. Like I did mention that radiofrequency ablation, having an intact cortex is protective. When you have ice or microwave, that is not true at all, right? So if you were to make an ice ball in the vertebral body, it doesn't matter if you're close to the cortex, that ice is going to form to whatever ice that's going to form for that particular probe. And that means that if you're close to here, you're really not going to see it until it's too late, and then you're freezing through the cortex into the cord or into the nerves. And if you've ever tried to see ice inside the bone, very hard, right? Unless you're like photon counting or doing something special, you're really not going to be able to see the different density changes within the bone. So this is a good location or a good example of what ice in the spine could look like. And so this person has painful metastases here to their T2 spinous process. Here we see it on the T2 and here on the post. You can see that it is involved in the spinous process, maybe a little bit into the lamina, but it's not, there's no epidural component or anything like that. So this is what it looks like on CT, very enhancing, right? Very vascular in this area. And so what we do here is we do our cryoablation. We put in some probes through the lesion. We place it in a way that we know the ice is going to form, right? Depending on what vendor you're using and what probe you're using, you know the size that that ice ball is going to make. And so we can place it here and then watch it sequentially with CTs so that you can see where that ice ball is going to. And that's the benefit of cryoablation and CT in general, right? Cryo will never really go away because you can sculpt ice to make kind of whatever shape you want, and then you can see it on CT, right? With RFA, unless you're doing RFA under MRI, which a lot of people are not, you cannot see those changes at all. Whereas on CT, you can see the cryoablation changes. So this is kind of what it looks like. We used a couple probes here to build a decent ice ball around it, and then we start to do some thermal protection, right? And so this is where that active thermal protection comes into play, where we put a spinal needle down interlaminar here into the epidural space. We put some CO2 in right here. If it doesn't go where you want it to go, then you put in some contrast or D5W or whatever instead, right? Something to physically displace the cord away. And these are all active thermal protection techniques. And then up here in the skin, right, you never want to get your ice ball coming up to the skin. That's going to cause some necrosis, wound healing issues, and very morbid afterwards. So displace that skin if you can with CO2. Again, right, a gas is going to be a better insulator than a liquid. So CO2 is ideal, but if you can't, right, sometimes gas goes wherever it wants to go, then you just put some liquid in there instead and push things away. And this is kind of what that looks like sequentially, right? So you can see these are the streaks from our needles here. And then as the cryoablation goes on, you can really see that ice ball start to form and really measure it. And that's really the benefit of cryoablation, right? Aside from the size, because that's bigger too, right? The ability to really see what you're ablating and measure those is ideal. This is what that looks like at the end, right? Big ice ball around that entire spinous process met. Everything is protected. And then, this is what it looked like 6 to 8 weeks later, right? We remember before it was enhancing the whole way through. It's all dead now. And again, this is normal to see these, right? If you guys are reading any MRIs after anybody's doing ablations, it's normal to have this thin kind of enhancement around it. You just don't want to see any of that nodular or mass-like enhancement. All right, so that's kind of a very brief intro to spine tumor interventions. Again, it's always an ever-increasing cancer diagnosis rate and osseous metastasis rate as our life expectancies continue to go up. The main thing for us, percutaneous ablation is often forgotten, right? If people are following the NCCN guidelines to a T, and ablation doesn't show up, we're kind of like an afterthought. And so that's very important to play a big role in that multidisciplinary tumor board. Really insert yourself into this patient's care and let them know about the things that you can offer them as a musculoskeletal interventionalist. Right, you got to have careful patient selection, detailed multidisciplinary approach, as I mentioned. And then, there's a lot of different modalities for ablation, heat or cold based, but in the spine, RFA is by far the most dominant. And that's with just the decades of data that we have now showing that it's safe and very controllable to produce a nice controlled ablation zone. And then we think about our active and passive thermal protection as well, which is a whole nother discussion on its own. That's it. Thank you guys. Again, any questions about this type of stuff is I know it's a little in depth, a little maybe a little advanced, but you could always reach out to me. I'm happy to answer any questions or anything. We do a lot of this stuff here at Mallinckrodt. You may not do as much at your guys' institutions, but it is something that you can learn and be of use to whatever practice you decide to go to.
Thanks, Dr. Imaoka. I don't see any questions in the chat, but I have a question myself, if that's okay.
Yeah, of course.
So at MGH in the musculoskeletal section, we do some interventional oncology work for orthopedic oncologists, but um, just because of sort of our structure, we don't do much in the spine. Um, and I found that I prefer using cryoablation because I feel that I have more confidence in my ablation zone. I find with RFA, I'm trusting a manufacturer's zone, and because it's so dependent upon the surrounding tissues for conductivity, uh, it forces me or it makes me feel like I can't have as much confidence. And particularly when you show like an example of a sclerotic lesion, um, I wonder if with a sclerotic lesion that we're accomplishing the heat that we need to actually cause necrosis in these lesions when we're using RFA, and if you have sort of thoughts on that.
Yeah, absolutely. That's a big thing. And that's actually the specific reason why we use the vendor we do, which is the example that I showed here, which is Merit. They're the only one that has thermocouples embedded into the probes itself, right? So you have physical proof that you are hitting a certain temperature at a certain distance from the center of your ablation zone. Right. And so that combined with what they showed in the lab where if you hit a 50 degrees temperature at this one, you're hitting a 3 by 2 centimeter ablation zone. That's the reason why we use that one, right? As what you said is absolutely true. If you're using, the other vendors like Stryker or Medtronic, things that are pretty common out there, actually, there's no way you're basically setting an algorithm and you're trusting that that algorithm is going to hit the desired temperatures for the desired amount of time. And the really only way you can prove it is by getting an MRI afterwards and seeing the ablation zone. But sometimes if that's the case, it may be already too late at that point, right? You've already cemented, now there's epidural growth, right? You kind of are burning your bridges if you do it that way. So I do agree that it's difficult with a lot of the other vendors out there. There are ways to know with our Merit specifically, thermocouples at certain at places where you have physical proof that it's there. As far as the sclerotic portions, there was a trend where we would do like prostate mets, or a lot of people would be doing prostate stuff, prostate, anything that's sclerotic with ice, because of that exact reason, right? You felt like the ice is going to definitively give you better temperatures that are lethal. But I would say nowadays that that's kind of fallen off from practice. There's a lot of people that have gone back to RFA again just because it's actually shown that it's working, and we've noticed it too, right? We still RFA blastic, prostate, colorectal, breast, and we're still able to achieve those temperatures. Or even if like you're doing something benign like an osteodacioma, right? Surrounded by so much sclerosis and everything. If you give the RFA time, it'll still make it, at least with what we're using where we can see the temperatures. So, but to your point, some people definitely do cryoablation for that specific reason.
Thanks. And then the one last question I have is, when you were talking about nerve monitoring and evoked potentials, I went through this recently in a case where I was treating a lesion in the fibula with the deep perineal and superficial perineal nerve sort of sitting on top of it.
Hmm.
And I decided to use RFA instead of cryo for the reasons that you mentioned, right, with the cortical protection of the bone. And but I was still very worried about these nerves. And when I talked to our neurophysiologists about what we could do, um, they mentioned evoked potentials, but it sounded to me as if we use this form of nerve monitoring, it wouldn't necessarily be live. It would sort of show me after I've injured the nerve that I've injured the nerve. And so instead, we opted to go for a sort of live EMG. I don't know if you have sort of an opinion on evoked potentials versus EMG, sort of in the setting of ablation.
Yeah, so the thing with the evoke potential is that, as you mentioned, yeah, it's passive. So right, you by the time something happens and you see it happening, right, the nerve is already pissed off at that point. And whether you're using cryo or RFA, what we and other people have found is that once you see those changes, if you stop your ablation there, the changes usually revert and they go back, and the nerve kind of responds. So it's not as if you see the changes and then it's over at that point. The nerve, you may have some chance to revert. And, I
Okay.
was talking to Jay Morrison out of Mayo about this. He uses it a lot for all his cases up there. And, he says that he sees it a lot where, they'll be ablating, they'll get a little bit of changes on the evoke potentials, but then they'll stop there and they always come back. He hasn't really lost anything off of that. What I will say is that depending on your EPs, I don't know how often they're firing, right? You can test them on cycles like seconds in between, or you can go minutes, right? So what we'll do is when we're using the EPs, we will let them know when we start ablating and how often we want them to test. I would say we're probably in the range of like every minute or something like that. We're testing it and just checking, and they're constantly telling us. But if you're very concerned, you could fire them even more frequent than that. But we do like that when we have to, but what we do prefer would be more active thermal protection. So, like in your example, what I might have tried to do is stick a needle in there and see if I could elevate that perineal nerve away from the fibula, either with just CO2, kind of insulate a little bit, or with hydrodissection to just kind of push it away, buffer it. Right? If you're using RFA, you can just use either room temperature or maybe slightly cooled fluid to just kind of buffer that. And that kind of, as well as using EPs, gives you that extra layer of protection, which is actually better because it's active protection instead of just waiting for the passive thermal protection to tell you that something is actually going on.
Thanks. Yeah, I had sort of the same thought. I guess my concern was that I was going to create an artifact on my nerve monitoring through
Mhm.
hydrodissection of the nerves. And because I had nerve monitoring, I opted to sort of, forego
Yeah.
any sort of hydrodissection. And I don't know, in your experience, have you noticed if you have nerve monitoring, if you do hydrodissection of nerves, do you get some abnormal evoked potentials or EMG?
No, we haven't had any issues with that or causing any artifact. I will say that when we cryo, the just in general, for whatever reason, cryoing creates a lot of background noise in the EMGs, the EPs. So usually our EPs can kind of see through the artifact and they'll let us know. But I feel like we see that all the time when we're specifically cryoing. But we have not had any issues where we're either doing CO2 or saline or whatever have you, where we're seeing any changes on the EP because of our active thermal protection.
That's super helpful. That will change my practice, so appreciate it.
Yep.
I don't think I see any other questions. Or here we go. We have a question that has just shown up. The question for you is, how do you approach staging larger lesions? Strategies to retreat areas? Question mark.
So larger lesions, that's a little difficult, right? If we're talking specifically in the spine, we're always trying to treat the entire spine anyways, regardless of the size of the lesion, because we're looking at it from like a rad-onc approach as well, right? We want to kill everything in that area. So that's kind of what, in addition to, or that's kind of, specific to the spine. When you treat the spine, you're never going to ablate the vertebral body like that much and not leave any cement. So you're kind of burning your bridges a little bit from that standpoint, right? It's unlikely that you're going to go back in afterwards. It is possible to drill through a PMMA through cement and do something else if you really needed to, but it's unlikely you're going to. If we're talking about other larger lesions outside of the spine in the pelvis, wherever, any other MSK-related lesion, you're looking at the size of the lesion, you're looking at the proximity to adjacent structures. Usually, if you're outside the spine from our standpoint of view, if you're outside the spine and you're looking at big lesions, you're thinking about cryo. Right, RFA can only get so big, or microwave potentially if you want to do it that route, but RFA can only get so big. So if you're looking at these big pelvic mets where the entire acetabulum is taken up by the cystolytic lesion, it's extending to the pelvis or the ischium or something like that, you're probably thinking about cryo. just to save you the time. All right. And then also cryo is good because when you're doing CTs, you can see the ice, right? So when you get bigger lesions, you're going to be more likely near to more intricate structures, whether that's the nerve, the bowels, the skin. So you're kind of thinking about that too, right? In general, big lesions, cryo, in a safe spot is cryo. Small lesions in bone, RFA is great for those too. And then if you want to see where you are, right? If you want to see the ablation zone and confirm it, cryo right now is the best way to go, right? Unless you're doing it with MR where you can see those changes, cryo with CT is where you're going to go for that.
All right. Well, thank you, Dr. Imaoka. I do not see any other questions. I would like to remind the attendees that there will be a survey in the chat, um, so we can get feedback on these resident education clubs, and we really hope you enjoyed it. Um, and thanks again, Dr. Yamaoka. That was very informative, and I know personally I learned a lot from it. So thanks a lot.
Yeah, I do want to add one more thing now that you just kind of remind me of it, but this is it seems a little advanced, but it's actually not that bad. And I think it's a lot of it just people, you aren't really exposed to it as much as you could be. And because of that, people are a little bit more nervous to get into, things like this. But, something that the Society of Interventional Oncology does is every year we do an MSK master class where we're talking about ablations, we're talking about augmentation, things like that that's related to the MSK world in the realm of interventional oncology. We do that every year, and it just happens to be that this year in October we're doing it at Washington University. So shameless plug here for coming to learn more about interventional oncology from the MSK standpoint. October 3rd is when we're going to do that this year.
Thanks for the thanks for that, Dr. Yamaoka. That's great. The other thing I want to mention is that there will be the next Resident Education Club webinar will be April 26th, 2026, and that will be on the oral board cases and strategies for MSK. That will be presented by Dr. Samer Susan. So again, that will be April 22nd, so next month. And that concludes our Resident Education Club webinar. And thanks everybody for your attendance. And thanks again, Dr. Yamaoka,
Thank
for the
you.
great presentation.